everyone. Thank you for coming. Welcome to NADO's 38th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments in the chat and questions in the Q&A. We hope you will take advantage of this opportunity to engage with our speakers and attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in our daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. I really do appreciate being with you for this session. We would like to recognize our session sponsor is Milliman Med Insight, and we just have a few words from them that we're going to read. Milliman Med Insight is an enterprise data management and analytic reporting organization. We deliver contextualized insights combining data intelligence from inside and outside your organization with powerful analytics derived from 70 years of industry-leading expertise. We work with 8 APCDs and multi-payer health plans across the country with a commitment to ensuring that our clients have the highest quality data and most advanced analytic groupers and methodologies with which to make data-driven decisions with confidence. It is paramount for our organization to stay up to date on policy trends and priorities at both the national and the state level to help align on further product development and innovation to ensure our clients are staying ahead of the curve. So again, thank you to Milliman Med Insight for sponsoring our session. This session is National and State Policy Trends and Priorities. Our moderator is Rong Yi, and who should be joining us at some point during the session. And we're going to go ahead and get started. Our first presenters will be Erica Plant and Kelly Dixon from the University of New Hampshire. Erica and Kelly.
Hello, and welcome to our presentation on analysis of the impact of COVID-19 on healthcare costs and utilization in New Hampshire. My name is Erica Plant, and I am a senior health data analyst at the University of New Hampshire's Institute for Health Policy and Practice. A majority of my work at IHPP centers around healthcare claims data and analysis under IHPP's Health Analytics and Informatics focal area. I am joined today by my colleague, Kelly Dixon. Kelly is a research associate for IHPP, whose current work primarily focuses within our long-term care and aging focal area, but she has been involved in projects across all our institution, including the COVID-19 analysis we will be presenting today. We have the following presenters' disclosures to share. Kelly has no conflicts of interest to disclose. I have a personal financial relationship with Lonza Biologics, a pharmaceutical manufacturer, through my husband, who is employed as a risk manager for that company and receives a salary, stock options, benefits, and retirement as compensation. In this presentation, the audience will learn how changes in service delivery align to policies made in response to the COVID-19 pandemic, which services were and were not impacted by the public health emergency response, and which services rebounded most quickly after the initial lockdowns in New Hampshire. Before we talk about the analysis, I would like to provide a quick overview of IHPP. Our organization resides within UNH's College of Health and Human Services. Within IHPP, there are 5 focal areas: health, law, and policy, delivery system and payment reform, health analytics and informatics, long-term care and aging, and public health and health promotion. The analysis we will present today was conducted within the health analytics and informatics focal area. IHPP has a data use agreement with the state of New Hampshire's Department of Health and Human Services to allow for access and analysis of New Hampshire's all-payer claims database. This provides us access to administrative claims and enrollment data for individuals with commercial health insurance policies based out of New Hampshire, as well as those insured by New Hampshire Medicaid and Medicare. We leveraged this access to data and our staff expertise to analyze how medical and pharmacy costs looked after the initial COVID-19 lockdowns. For this analysis, we used commercial medical and pharmacy claims data from January 2019 through December 2021. For historical context, here's a basic timeline for key events in New Hampshire during the first 2 years of the pandemic that we overlaid with the total number of reported COVID cases in the state. This data was collected from the state of New Hampshire's public-facing COVID-19 dashboard. As many of us all know, the WHO declared COVID-19 as a pandemic on March 11th, 2020. 2 days later, on March 13th, Governor Chris Sununu declared a state of emergency in New Hampshire. With this declaration, non-essential businesses closed, elective healthcare services were postponed, and residential care facilities for older adult patients began to prohibit visitors. In May of 2020, Governor Sununu allowed New Hampshire businesses to reopen with specific guidelines to follow, and healthcare services could phase in selected non-essential practices and procedures. We know that the COVID-19 pandemic and the public health emergency response significantly impacted access to and use of healthcare services during the early months of 2020. But we also wanted to know if an impact was reflected in medical and pharmacy administrative claims following the initial lockdowns. In our effort to investigate the impact of the COVID-19 lockdowns on healthcare utilization and costs, we conducted observational analysis of medical and pharmacy claims data from January 2019 to December 2021. We defined pre-COVID as the period of January 2019 to February 2020, the COVID period as March 2020 to May 2020, and the post-COVID period as June 2020 to December 2021. For the medical claims analysis, we calculated per member per month costs for high-level medical types of services, such as professional claims for an emergency room. We chose to use PMPM costs as it reflects the total paid amount for medical services spread across all members for the month. For the pharmacy claims analysis, we calculated prescription rates per 1,000 members, as well as PMPM costs for pharmacy drug classes, such as antidepressants or analgesics. I am now going to pass the presentation over to Kelly, who is going to highlight our key findings in this analysis.
Thank you, Erica. The key findings of the analysis indicate that in New Hampshire, the average per member per month cost for medical services dropped from $304 in January of 2020 to $138 in April of 2020. This aligns with the governmental mandates requiring non-essential medical services and procedures to be postponed, thus impacting the utilization of healthcare services. During post-COVID, the average costs were equal to or higher than pre-COVID rates among all medical services. In contrast, with the exception of March 2021, the pharmacy average PMPM costs increased consistently in 2020 and 2021. Further analysis explored which costs of medical types of services rebounded most quickly. We also looked at which drug classes experienced the greatest increases in average cost and the frequency of prescriptions year over year. In the medical claims, we found that the PMPMs for 3 types of services rebounded to their pre-COVID rates sooner than others. These were facility outpatient surgical, professional radiology, and professional surgical. These surgical and radiology services returned to pre-COVID PMPM costs by June 2020, just 2 months after the lockdown. The 2 types of services that were slowest to return to pre-COVID PMPM costs were professional emergency room and professional medical. These service types did not rebound until August and September of 2020. When investigating pharmacy claims, the analysis showed that the average PMPM pharmaceutical costs increased by more than $35 from 2019 to 2021 in New Hampshire. Among the top 10 drug classes, the average PMPM cost remained stable each year except for bronchodilators and immunostimulants. The average cost of bronchodilators increased by $16 from 2019 to 2021, while the average cost of immunostimulants decreased by $18 over these 3 years. Comparatively, when reviewing the types of drug classes in terms of the frequency of prescriptions versus cost, the rate of prescriptions among several classes increased. Immunostimulants were the class with the largest increase in the rate of prescriptions, which increased over 200% from 2019 to 2021. This was followed by 3 drug classes often prescribed for mental health conditions. Central nervous system stimulants, which increased by 26%, anticonvulsants, which increased by 21%, and antidepressants, which also increased by 21% over the 3-year period. This concludes our presentation. Erica and I thank you for taking the time to join us today. Links to the reference report of this analysis and to our 2 data reporting modules are provided on this slide. We have also provided our contact information for any questions you may have after this presentation. Thank you.
Thank you, Erica and Kelly. That was a very engaging conversation. I'm not seeing any questions yet in the audience from the audience, but we do have a few that we have prepared in advance for you. So take a look at this. So in analyzing state level cost trends and utilization rates, did you come across any unique challenges? And if so, how did you navigate those?
Yeah, thanks. So our analysis kind of had a unique challenge in the fact that we actually had like too much data. We have over 260 types of services that we are able to map to in our claims data process. And so when we were deciding to create these briefs, which are about 5 pages total, that we publish pretty widely, and they're not meant for peer-reviewed publications. They're meant for wide distribution. We had to distill down to the main points. And that is actually, I think, a challenge that many people can relate to, where you actually have too much data. We also have a multidisciplinary team. So it was really interesting to see different aspects and thoughts about how to communicate our findings. So say someone from our law team may see a different view, like through policy, versus someone like myself who has more of an analytical thinking brain. So while that's always a blessing, it can sometimes make it a little bit unwieldy to get the meaningful information out there.
That makes total sense. Can you share with us the current progress of your research and any of the subsequent steps that you're considering? Like what's next?
Yeah, thanks. So we are actually continually updating. We have a report suite of claims data for basically all of our payers that we have access to. So the commercial claims, the Medicaid, and the Medicare. And we actually recently just got a bunch of extracts that include 2022. And so it will be really interesting to see once we'll be publishing that in the next month or two, and we'll be able to kind of see some interesting results now that we are even further out from that 2020 moment. And so while there isn't necessarily a defined absolute question like these briefs approached, we may find new things. There's a lot of discussion out there of the impact of COVID-19 and its long-term effects. We are also partnering with another institute at the University of New Hampshire, working on long COVID, researching long COVID as it pertains to individuals with disabilities and the workforce. So directly this particular question, maybe we'll come back around to it as we have new data. But we're also doing other pieces of work in the field.
All right, well, thank you. I don't see any questions from the audience at this time, but just so that everybody knows, we will have time at the end for Erica and Kelly to respond to those questions. So if you have ideas or thoughts in your minds, go ahead and drop those in the Q&A, and we will come back to those at the end. Thank you. Thank you. And we're now going to hear from Pam Mink from the Minnesota Department of Health. Pam, let's go ahead and turn it over to you.
Hello, I'm going to talk to you today about the Minnesota study of telehealth expansion and payment parity. So quick overview of what I'll be talking about today. I'll provide some brief background on telehealth policies in Minnesota, a bit about the legislatively directed Minnesota study of telehealth expansion and payment parity, some high-level findings to date, some data challenges and considerations, and then finish off with some links of where to find our reports, and then have time for questions. The 2015 Minnesota Telemedicine Act first defined what is telemedicine, most notably that telemedicine, the definition does not include audio-only or telephone-only interactions. It also sets some guardrails and restrictions around who can provide or receive telehealth care services and under what circumstances, and then establish payment parity requirements that telehealth visits be reimbursed at the same level as in-person care, as comparable in-person care. In 2020, along with the pandemic, came some emergency orders which eased many of the restrictions that had been put in place around telehealth, both at the state level and at the federal level. During this time, audio only became an acceptable and billable use of telehealth. And then with the 2021 Minnesota Telemedicine Act, many of these provisions, these emergency order provisions, were codified into law. The 2021 Minnesota Telehealth Act then expanded telehealth in Minnesota. It extended payment parity to include telephone-only visits, as well as including telephone-only visits in the definition of telehealth. There was a sunset on this that it was originally June of 2023, now extended to June of 2025 so that it could be continuously evaluated. And then it directed the Minnesota Department of Health to conduct a study of the impact of these policies under private health insurance. A parallel study is being led by our colleagues at the Minnesota Department of Human Services, and that's focusing on the impact of telehealth regarding Minnesota healthcare programs, including Medicaid and Minnesota Care, which is our basic health program. The Minnesota legislature has set forth a number of questions to be addressed by the telehealth study. In broad terms, the MDH study will evaluate the impact of telehealth expansion and payment parity under private sector health insurance on access to healthcare, quality of care, health outcomes, patient satisfaction, innovation in healthcare delivery, as well as any value-based or alternative payment models. Also to look at the impact on healthcare disparities and equitable access for underserved communities, any impact on healthcare costs and premiums, and any impact on access to and availability of in-person care, especially in rural areas of the state. The legislature also directed us to address the extent to which services provided through telehealth may substitute for in-person services or are being done in addition to in-person services, including whether they are duplicative. Also address the services and populations for which increased access to telehealth improves or negatively impacts health outcomes, whether audio-only communication as a permitted option for delivering services supports equitable access to healthcare services, including behavioral health services, and whether having access to audio-only healthcare eliminates barriers to care experienced by vulnerable and underserved populations without reducing the quality of care or worsening health outcomes. And then finally, how payers ensure that telehealth services are appropriate to patient needs and remain optional. So those are a lot of questions. And so we embarked on a very large multi-method study to pull together data and other information from a range of sources. So conducting literature search, including a focused literature review of audio-only telehealth. We've been looking at policies and studies being done in other states. As part of the qualitative arm of the study, there have been interviews with Minnesota patients, with providers, with payers, additional key informant interviews, and group discussions. The quantitative arm of the study includes analysis of healthcare claims data from the Minnesota All-Payer Claims Database, as well as analysis of data from electronic health records being led by the Minnesota EHR Consortium, a number of MDH surveys conducted among Minnesotans, conducted with ambulatory clinics and with the healthcare workforce. So either adding questions or making use of existing questions on telehealth in those surveys. We have assembled a technical advisory group to consult with and advise us along the way. We had a workshop in February on policy-informed telehealth research, and then just ongoing stakeholder engagement, lots of conversations, lots of learning, lots of questions and answers with stakeholders. So a lot of data are coming in, and I won't try to summarize it all for you today. What I will do is just talk about some of the big dramatic changes that have occurred due to the disruptions and needs related to the COVID-19 pandemic. So I'll talk about the impact that this has had on the overall volume of telehealth use, on the types of providers who are offering care via telehealth, and the changes in the types of conditions or services for which telehealth is used. These figures show the dramatic increase in the volume of telehealth. On the left, it shows the proportion of E&M visits delivered via telehealth. And what you can see are the very, very low pre-pandemic levels, the peak that happened in spring 2020. Then things went down, but leveled off at a level much higher than pre-pandemic. And this was particularly high for mental health care. And that figure is just showing for commercial enrollees. On the right, you see the proportion of enrollees with at least one telehealth visit in each of 3 years by insurance type. And so during the early parts of the pandemic, the highest use was by Medicare enrollees, which then dropped quite a bit in 2021. For commercial and Medicaid enrollees, the drop from 2020 to 2021 was much less pronounced than what you see for Medicare. There was also an expansion of the providers offering telehealth, with the most notable change being the availability and use of telehealth from usual brick and mortar clinic-based providers. In the commercial space, most telehealth provided pre-pandemic was offered through virtual care platforms. In addition to increased use of virtual care providers, with COVID, most health systems and clinics now offer telehealth visits. On the right, you see the proportion of licensed providers who offer at least some degree of telehealth. This grew and stayed high with the pandemic and was highest for mental health providers. And this slide shows how the most common conditions being treated in a telehealth visit have changed. In 2019, 3 of the top 5 diagnoses were for non-emergency acute care conditions: sinusitis, urinary tract infection, and conjunctivitis. Whereas in 2020 and 2021, mental health conditions made up 4 of the top 5 diagnoses, particularly anxiety and depression. So briefly, some data challenges and considerations. The first being, really, what are we talking about when we talk about telehealth? Are we using a broad definition or a narrower definition? And our definition changed throughout the study depending on the source of data. So sometimes it was the broad, include everything. Sometimes it was narrower, focusing on real-time telehealth providers. And then in interviews, we were able to go more deeply into very specific uses of telehealth, such as telestroke, diabetes prevention, and other applications. Another challenge is really just the rapid change in telehealth use over a relatively short period of time. So if we're looking at data from 2021, what does that tell us about uses and relevance in 2023? It's not clear yet whether telehealth patterns have truly stabilized, what the new normal is. And then the codes, there were a lot of new codes that came online during COVID and after as well. The different data sources allow you to ask different types of questions. There are always trade-offs with each, but if you can use them together, they can be very complementary and help to fill out the picture. This slide shows some of those considerations in choosing data. And finally, here's some links to where you can find our preliminary study and where our final report will be available on the MDH website. Some acknowledgements here, and then thank you very much.
All right, fabulous. Thank you, Pam. We do have, well, I have questions. Like they're not really from the audience, they're from me. So the first question is, I noticed that the 2015 Act was referred to as a Telemedicine Act and 2021 as the Telehealth Act. What's the difference, and does the 22 Act include a broader set of services, or why did they make that change?
Thanks for the question. I couldn't say exactly why the legislature decided to call the act one thing and the other, but there are some differences in formal definitions. So telemedicine is really confined to sort of remote provision or delivery of clinical services, and telehealth is a little broader and includes things like
patient portals and other sort of ways that technology is used in the interest of health and healthcare. The big change from the 2015 Telemedicine Act to the 2021 Telehealth Act was the that audio only or telephone telehealth counted in the definition of telehealth, and that meant that it needed to be or currently needs to be reimbursed at parity with in-person care. Other than that, it's really just restrictions were sort of relieved and things became more flexible.
Very good. So another question, I noticed that you were comparing APCD claims data with EHR data. And I was just kind of wondering if you could expound, like, did you actually link APCDs with EHRs? And if you did that, did you do it for everybody or a representative sample, or how does that comparison work?
Sure. And I didn't say much about the EHR data. Basically, the study, we were pulling together data from a lot of different sources, but not doing any sort of linkage. And in this case, linking the EHR data with the APCD data would have been a big, heavy lift for us, and mostly because the Minnesota, not just because of the Minnesota EHR consortium, but the way that they operate, they're really kind of almost a voluntary, although we support them. And the work they did for us was engaged through a contract, but they're really a consortium of the willing and volunteers. And the way that they operate is, for a study like this, we determine the research questions, they write the code and then distribute it to the different health systems who then run the analyses, and then it goes back to their coordinating center to compile them and aggregate them. So there's not that individual level data. There's not one repository that has all the data and then you just go into it. It's really pulled for that. And then with the Minnesota APCD, we have some limitations too about not having identifiers to do a linkage. So I think a linkage itself will be a challenge. We probably wouldn't start with the EHR consortium. And even though the idea of having those data linked would be fantastic, I think it would be a multi-year project to pull it together for us.
So, I mean, this is one of the questions that we have had about Minnesota and your restrictions on identifying fields. So is it even a theoretical possibility, the way that your data comes in, to do something like this? Or is it just not, at this point, not feasible and can't be done? Or is it just a lot of work?
So I think all of kind of combinations of things in terms of what's feasible and what isn't. Some of it is, we have to always operate within the confines of our statute and what we're able to do. We are considering sort of proof of concepts for doing, to seeing to what extent we could link. We just wouldn't do it on such a big scale. Yeah. So, we're talking to a health system right now about the possibility of doing a linkage, but we don't know how well it's going to work, in large part because the identifiers they have and the that they would submit to the same hashing algorithm that our submitters go through to submit their data. We're just not sure to what extent those identifiers will line up in a way that we can determine a good match. So it's sort of a probabilistic approach, I think, at best.
Well, I didn't want to get too deep in the weeds on the technical part about linkage, because I'm sure there's a lot more to say, but what would you say is the most important thing that you have learned from this exercise so far?
From the telehealth study?
Yeah.
I think that's a big question, and we're working on our final report. It's on the one hand been a huge transformation in healthcare. I think that the evidence that we've collected to date, and I think nationally too, points to comparability in many areas, but there are always those, kind of unseen negative aspects of it that could happen too. So I think it's really kind of a stay tuned, still a work in progress. And the challenge is, how do we inform the policies that need to happen today for some questions that we won't have answers to for another, couple of years, if not longer.
Very good, thank you. And by the way, just a reminder to the audience, we will have time at the end for additional Q&A and group discussion. So if you have questions for the group, go ahead and put those in the chat or the Q&A tab, and we will catch those at the end. Thank you, Pam. We're now going to hear from Marian Robel from Mathematica. So Marian, we are ready for you.
Hi, everyone. I'm Marian Robel from Mathematica, and I appreciate the opportunity to talk to NATO. My remarks are based on my observations of several benchmark programs and my expectations regarding CMS's AHEAD model. The topic of this presentation is how a current state policy initiative uses data and how a future one might also use data building on that experience. And the purpose is to get health data organizations thinking about how they can contribute and to get state policy folks thinking about how their HDOs can contribute. And first, I'm going to talk about benchmark programs where the policy community has a 10-year 8-state track record, and then I'm going to use that experience to consider what might be possible and relevant under AHEAD. What are cost growth benchmark programs? They are state-led efforts to help make healthcare more affordable. They begin with a compact among various stakeholders to keep cost growth at or below a target level, and then they tend to use data in two distinct ways. One is they collect aggregate data on spending and use that collected data to hold various entities and the state as a whole to their commitment. And secondly, they analyze available secondary data and use that data to generate insights on cost drivers and cost containment strategies. And in that second work, there will tend to be complementary analyses of access, quality, and equity. So how do health data organizations fit in? During the design phase, they often select and model the economic indicators that will set the benchmark, and during the implementation phase, they may be involved in designing the data tool, determining which organizations must submit data, overseeing the actual data collection, and validating the data that come in. So the second prong of work, analyses of cost drivers and strategies. APCDs are the workhorse here. I note 3 uses on the slide, but unfortunately, I don't have time to discuss. I wanted to talk specifically about equity and social determinants, very important to the policy community, very important to AHEAD. States have many purposes in this arena. They want to analyze equity and social determinants. They want to adjust benchmarks for social determinants. They want to be able to measure progress over time. They want to be able to compare providers and payers and areas cross-sectionally. And finally, when they do have findings, they want to be able to put that into context. And at the same time, communities themselves want to use data, and they want that data to be relevant, accessible, and responsive to them. You know, I like the tagline, "Nothing about us without us," and I have to acknowledge, as someone who's been in this field for 20 years, it's a change. A lot of us are accustomed to thinking of our primary audience as other experts. And finally, there are the natural, important roles for health data organizations, collecting data, advocating for data collection, using imputation in a thoughtful manner, and incorporating other area measures of social determinants, including C codes, into data files to allow people to do these analyses. So this brings us to the HEAD program, and the focus of a HEAD can be seen in the acronym. It's a state program, it's an all-payer program, and it is a health equity program. It brings Medicare into the fold of state health policy, Medicare being the big gorilla. So let's break it down for health data organizations and zero in on a few specific items. There are new payment methods for hospitals, global budget payments, and also for primary care. We need social risk adjustment in both cases. There are bonuses for hospitals when they improve disparity-focused measures. There is an insistence on enhanced demographic data collection by hospitals and primary care, and that data may potentially swim upstream through payers to APCDs, and there is a requirement around social needs screening and connections to community resources. And throughout, there is a need to collaborate with CMS. So, drawing on our knowledge of benchmarking programs, we can think about the potential roles for health data organizations under a HEAD. They may be collecting new data. They may be playing a role in this platform to connect providers and community agencies. There may be a call for them to integrate Medicare and Medicaid data in ways they haven't before, or there may be a call for them to align analytic work closely with the public agencies. Okay, I'm going to talk about one use case here, which is global budgets. My husband loves the scene from Jaws where he says, we're going to need a bigger boat. And I have to say, for global budgets, states may not need bigger data, but they're going to need to use their data in new ways. They are going to need to assess whether to join the AHEAD program at all. And if they do, they're going to need to set global budgets. For that, they need all kinds of hospital-level volumes, paid amounts. They need data on payer mix and patient characteristics. They need the area-level data so the hospital's population is understood and the burden of disease. They need all kinds of provider information, and they need trends to look forward. Not only do states need that data, but hospitals need that data, both to decide whether to join the model and then to succeed under it. Remember, hospitals may not have the comprehensive view of their populations that an APCD can provide. And finally, although I've been talking about APCDs, APCDs offer that rich detail, but they do have blind spots in terms of populations that aren't included. Your hospital discharge data can be used in a complementary manner for that comprehensive view. Again, I'm going to talk about a few other APCD use cases, although there are many of these. One is AHEAD has accountability for cost growth, so APCDs can do those same types of things that they have been doing in benchmark programs, analyzing cost growth. AHEAD calls for investment in primary care. APCDs can be used to help target that investment, to understand health status and service utilization, figure out where we get the biggest impact for our dollar. And finally, with those hospital bonuses for disparity-focused measures, APCDs can be used to test various measures and model variation in order to choose the ones that will be most powerful. So in conclusion, AHEAD is an exciting opportunity for states to improve healthcare value and to have the force of CMS behind them. there are all kinds of things that states can draw on data for and will want to. Their health data organizations will be critical partners, and we have really strong groundwork in what we've learned in our benchmark programs. Of course, we also have strong groundwork in what have been learned in those 3 focal states I mentioned. Okay, I look forward to the upcoming discussion.
Thank you, Marion. Fantastic. Nicely done. I do have a few questions for you, and maybe the audience will have some as well, so hopefully they will join in, but let's get started here. CMS referenced 3 states when they were laying out the general vision of the AHEAD model: Maryland, Pennsylvania, Vermont. What did they do? What kind of great things were they doing to get mentioned by CMS as kind of foundational for all of this?
Okay. Well, Norm, it's always terrifying to watch and listen to yourself on video. And one of the things that I noticed, along with the things a person always notices, was I think I went out of my way to note that those were focal states, but to note that the focus of my work to date has been benchmark programs. However, several colleagues at Mathematica, Shule Gurevich and Sandra Chow, have been working closely with all 3 of those states, and I've learned just a little bit from them. Maryland, you might say, is the grandmother of state health payment reform. They've had a waiver from CMS for their hospital rate setting program for 30 years. And in their latest CMMI model, they shifted virtually all of their hospital payment into global payments. And that program also has quality and total cost of care outcomes affecting payments, just like is envisioned under AHEAD. And so their concept for some time has been, predictable revenue for hospitals, incentives to that are aligned with patient health, not volume, and a push for cost containment. Maryland,
Okay.
sorry.
Oh, go ahead.
I'll try to be briefer on the other 2 states. Pennsylvania also has a voluntary global budget program for rural hospitals, and that's got, I think, 18 hospitals in it. And then Vermont has long been supporting primary care investment and has an all-payer ACO that is an all-payer ACO, like has Medicaid and Medicare in it too, and promotes care coordination and accountability for total cost of care.
Okay, so we do have a comment and a question here from Hiroko. So CMS is applying a risk-adjusted payments that account for social determinants of health to the REACH program, and also considering an application for the MA Star. They've got MA Star currently uses some case mix based on duals and social conditions. But do you think that CMS is expecting out of this new risk adjusters that could help kind of address some of those issues? Or is that just not related to this?
I think I would be speculating. I don't think the NFO notice of financial opportunity has come out yet. Most of the information I've seen is pretty high level. So I don't know what CMS is envisioning.
Okay, well, let's go ahead and bring all of our presenters back on stage. We do have a couple of questions and some discussion here. So welcome back, Pam and Erica. And let's see, Kelly, there we go. All right, and so we do have one follow-up question from earlier that came in after you finished. Erica and Kelly, this is from Simon. Sorry if I missed it, but how were drug classes determined?
Yeah, sorry. We did mention it, but very, very quickly, so I'm not surprised if it was missed. We have access to a database through, it's called Up to Date. We've actually since switched to a different database source, but basically we link that database to the National Drug Code to assign drug classes.
Okay. And then we have another question for Marion. So one of your use cases was about subcapitation. Could you just tell us a bit more about subcapitation? And you suggested that APCD might be able to fill the data gap and how conceptually that might work.
Okay. So that was one of those use cases where I'm the user with the need and I haven't designed the solution. I was hoping to throw that out there. But I know that, some payers, when they subcapitate, don't actually see the resource use of individual patients under those arrangements. And it creates a blind spot and a growing blind spot. And it occurred to me that APCDs could either play a role, and I think some already may, by collecting that data from these secondary vendors and finding ways to merge it on, or at least analyze it in conjunction with other data. Or that if that were not possible, APCD researchers could develop some of the methods using the places where we do have a full claims record to think about how we might impute or have insights about the places where we don't. So that was one of those, hey, all you PhD candidates out there, hey, all you professionals wanting to make your mark, here's something I know the field needs kind of comments.
There we go. Well, that's perfect. That's hopefully people who are watching can take that to heart. I do have one question I would like all three of you to address, and we'll start with Pam and then go to Erica and Kelly and then back to Marion. So the title of this session is National and State Policy Trends and Priorities. Pam, what is the most impactful thing that you have seen health data being used to influence either national policy or a state policy? Give us one example of where data really made, I'm sorry to put you on the spot because you're first, but I'll give you a second to think about that, where health data has actually been able to inform a fairly important decision, either with your state government or at the national policy level.
That is a great question. And it's hard to know, I think, where to start. Because I think, I think overall we sort of want, health policy to be evidence-based, and there's not just one example because there's not just one policy. So I think, I'll answer your question pretty generally, and I'll probably, wake up in the middle of the night and think of really great examples to illustrate. But I think it's, I think data are really helpful and necessary for identifying and illuminating a problem, or an issue that needs to be addressed, whether it is, inequities or disparities in quality or in access to care, or to sort of pinpoint interventions if you see, like, where in the state do you have higher rates of certain conditions or certain adverse outcomes. So it helps to kind of identify issues that need more focus. And then I think it also can be used to track progress. So if you do enact a policy that is meant to help with any of these things, to promote health, the data are what you need to be able to sort of track progress toward meeting those goals. So is there one example that comes to mind? No. But again, maybe I'll let others respond and see if something rises to the top. Yeah. But I think in general,
okay, so let's do this. Let's have,
for everything we do.
let's have Erica and Kelly take a crack at that. And then I've got a different question for Marion, and I've got a different question for you, Pam. So we'll be coming back around. So Erica and Kelly, if you want to take a crack at that.
Well, and I feel lucky that I'm second. So I had a moment to think, and like Pam, I'll probably think of something else later. But what does come to mind immediately for me is the introduction of the adult Medicaid dental benefit here in New Hampshire. It would be incorrect for me to say that health data was the only thing that helped. There was a ton of advocacy in the state and a lot of collaboration, some of which IEEE was part of, some of which it wasn't. But I think data helped inform that work, some of which, again, we were able to help provide and inform. But again, a lot of people worked towards that. So I don't want to insinuate it was one step. But for a long time, Medicaid did not have an adult dental benefit, and they do now. And it'll be interesting to see because the data is still, I don't think it's quite there yet for us to access it to see what it looks like. But it's kind of a nice thing that's happened.
Okay. So Marion, here's your question. Do you think states without an APCD will be in a position to apply for the AHEAD opportunity?
Yes, I absolutely do. Again, pure speculation, but I think even though I'm in the business of advocating for data and I'm a big fan of APCDs, I think with discharge data, with the claims data from the Healthcare Cost Institute, with Medicaid and Medicare data, with many other forms of knowledge, of course, there will be ways for all states that are genuinely interested to take a run at it.
Okay, good. Thank you.
But I'm speculating, right?
Yeah, no, that's the business we're in, is trying to forecast what federal minds are thinking, right? So, all right. So Yaying has a question here. I'm going to give this one back to you, Pam. With AI involved in our healthcare system, do you anticipate that telemedicine will be used more and more, especially in countries, areas that lack experienced doctors and nurses?
So I can't speak as much to the role of AI, but I think, it's a big question about areas where there are provider shortages, whether it's within the state of Minnesota or across the country or in other countries. I think it's for any of the considerations of telehealth, it's always a balance. It's, on the one hand, you want to do what you can to increase access for people in areas where there are limited options for in-person care, or even limited options for interacting with a specialist for any type of care, depending on your condition. The sort of the counterpoint to all of that is where, it's like, yes, telehealth could do a lot to help with that. You have to think about what is it that you ultimately want? Do you want to make the care available for people when they need it? You also have to think about, do you still continue with efforts, and I think you should, with making sure there are in-person options available for people. So sometimes the reality is, in the present, the in-person might not be available, and telehealth can be a great way to sort of fill those gaps. But for longer term, you still, need to consider, is that okay? Or do you, what do you do to increase people going into the professions and wanting to live and work in outside of big metropolitan areas in the U.S.?
Okay, very good. Now we are going to come back to Marion. I told you I wasn't going to ask you that question, but I am going to ask you the question after all, because I don't have anything else to ask you. So let's ask you that question about an opportunity where you have seen for health data to really move the needle on state or national policy.
Norm, I didn't listen well, so I have an answer to another question that I think I want to give, but then I'll come. No, I don't think I really can. One of the things that has been really striking to me is most of us have seen the comparisons that show the US spends more on healthcare relative to our international peers, has higher infant mortality, lower life expectancy. Our other peers spend, more on social services and have better health overall. And I feel that in the circles I move in, which are, college educated East Coast circles, but nonetheless, when I used to tell people I worked on healthcare costs, they would change the subject. And now they say, that's so important. We really need to get more value. And they quote those basic facts. So, kind of to complement what Pam talked about, which was sort of a more specialist issues in progress in terms of a sort of more widely disseminated mindset to support our work, those facts stand out for me.
No, that's fantastic. In fact, you touched on something which is critical in media relations, which is it doesn't matter what question they ask you, answer the question you wanted them to ask you. Which is, so now I'm going to do that for the other two as well. So like, what question do you want to answer? And go ahead and give your answer. Pam, do you want to go first and tell us what it is that what do you really want to tell us that I haven't asked you?
I think we're focused at this conference on data, and rightly so, and a lot about data from APCDs and HDDs and other kinds of information. I think for what I would say for the telehealth study is that it really, to get a full picture of the impact of the policy, which is what we're trying to do, it's a team sport, and you really need data from a lot of different sources. And I think Marion was sort of getting at this a little bit in what she said about the people she talks to. It's like people have their stories, and their stories are very important, and so the data are very important. And when they line up, it seems to strengthen sort of your case or the argument you're making or what you're showing. And so I think to really even though it might not be each of our individual jobs to collect, whether it's qualitative data or other things, I mean, we really in this study benefited by having not only the data from the All Payer Claims Database and the EHR Consortium, but also from different MDH surveys of Minnesotans, of healthcare providers, of clinics, as well as talking to people and engaging with stakeholders. So I think really it's the big picture is really important.
Okay, very good. Erica or Kelly or both?
Yeah, so I guess I can answer it from the data analyst kind of perspective. In thinking about this and how we're presenting it, and even my answer about our unique challenges, I am often always thinking about what is this? How do we get this out there? What can it do for policy moving forward? And I'm continually asking myself and thinking about that with everything that I put out there or work on. And that's, I think, a great question that was even in just the coffee hour I was just in earlier today. It's things that we all have to think about. Okay, many of us have gotten to a great point of getting all the data to the extent that we can with, allowances and such. Really, what are we doing with it? And like, what's the most meaningful way to enact change? I want to give Kelly a second too if she has anything to add.
I echo everything everyone has said.
Oh no. I don't. Should we let her off with that? Kelly, you have to tell us one thing that has not been said.
I will give credit to Kelly too. Kelly comes into this as she has been with IHBP for 5 years and started as an intern and has learned so many different aspects of what we've done and has jumped into everything that we have asked her to, and also led a lot of the data collection in that graph that you saw. That is probably the most work of the project, was to create that graph. So, I'll let maybe Kelly, if you want to say something a little bit about how difficult that was in itself.
Yeah, navigating the approach to the data publications and stuff was an experience. But I'm a very visual person, and I think data visuals are important for, telling a story and making sure the audience, can comprehend something that maybe us data analysts do, So yeah, that graph, I don't, yeah, there is a lot, but it's important work. So
it is, and we had a session yesterday that talked about the complexities of communicating data, and exactly, I think you're hitting on that, the importance of being able to create visualizations and ways of expressing. Well, thank you all. Just for our audience, right now we're going to open up the rooms for the health data deep dives. So we have 4 rooms again today, and I guess yesterday I didn't realize this that almost all of them were full most of the time. So you might want to head over there and find a place. But it's just an opportunity to network and to get to know people and to chat with folks. So thank you all again. This broadcast, as with all broadcasts, will be up on this same spot in about an hour. You'll be able to watch the video replay. Just take some time for that video to process and get uploaded. And again, thank you everyone, and we will see you all in just a bit for another session. Bye-bye.